Hello, my name is Kathy Cruz and my presentation today is on simulation learning in healthcare. I hope you find it informative. Many healthcare providers in the clinical setting are familiar with simulation in some form or another, from the use of mannequins to practicing first 5 mock codes on CPR certification. Simulation learning is a method of practicing and developing skills using hypothetical or artificial situations. There are many benefits to using this model of learning as an enhancement to traditional study and hands-on clinical practice. According to the text, simulation learning is a trial and error method which uses possible or probable experiences which are created to help reinforce behaviors learned in a traditional learning setting. It is meant to act as a bridge between classroom and clinical experience. Simulation learning has been shown to teach critical thinking and high-level decision-making skills. The goal is to improve patient safety and outcomes by allowing learners to make decisions, evaluate effectiveness of actions, and witness consequences in a low-risk setting. Simulation learning should be innovative, effective, efficient, safe, and of high quality. According to the Society for Simulation in Healthcare, simulation teaching serves 4 main purposes: education, assessment, research, and health system integration in facilitating patient safety. Education can be anything from roundtable discussions of case studies to full role-playing opportunities. Simulation can be used in assessment when people are learning new skills or for things like competencies. Patients can also be taught using simulation. For example, if a patient has just received an EpiPen for the first time and needs to be taught how to inject it using the training injector included. In situations where maybe something went wrong on the clinical floor, simulation can be used to review and research what went wrong in the process in order to ensure better outcomes in the future. Lastly, it can be used to evaluate current practice, to emulate healthcare behaviors to ensure safe patient handling. One example of this is how new patient care assistants and registered nurses are taught to use lifts in orientation by having someone play the patient and go for a ride in the lift. An important component of simulation learning is discussion following the simulated experience. This allows for debriefing of the events which occurred, the decisions which were made, the actions and consequences, possible alternative actions and possible alternative consequences, and suggestions for improvement. Simulated experiences and real experiences are never exactly the same. Therefore, multiple scenarios should be discussed in the debriefing session to cover as much information as possible. Ideally, the simulated experience would be followed up with a similar real experience as soon as possible in order to ensure the teaching was effective. There are 4 types of simulation teaching: written, clinical, model, and computer-based simulation. These all can be used in multiple settings in healthcare, education for clinical staff, leadership, and patients. Written simulation includes things like case studies, which can be discussed in group settings. Computer simulation can also be completed in groups and discussed, or can be used in individual training for things like annual competencies and the online portion of CPR training currently in use. Model and clinical simulations are probably the most well-known and frequently used. Model simulation can be utilized either with mannequins or role-playing with peers. Role-playing is defined in the text as unrehearsed dramatization, and much of simulation learning does involve role-play. There are multiple advantages to utilizing simulation for learning in healthcare other than those previously mentioned. It can improve psychomotor skills development, enhance problem-solving skills, and increase interactive abilities in cognitive and affective domains of learning. Simulation also provides experiences involving active learning in real-life situations with minimal risk to patient outcomes. There are some limitations to simulation learning. As with anything in healthcare or really any field of study, cost is a factor. It can be expensive to invest in the technology needed for the sim man and to pay someone to learn to manage it effectively for different scenarios. It is labor intensive to set up and time consuming to create, act out, and debrief each situation, which can be putting a strain on an already overworked staff. Also, this is technology which is not readily available to all health systems. One of the reasons so many of us are familiar with simulation training is where we are attending school. Pennsylvania College of Health Sciences was included in a study completed by the National Council of State Boards of Nursing a few years ago in an effort to assess the efficacy of simulation-based training. So the council states that simulation effectively augments traditional clinical experiences across pre-licensure nursing care. Studies also link simulation education with better academic performance and increased patient satisfaction. According to Abbas and Juma, simulation experiences consolidate learning, develop critical reasoning skills, and deepens understanding of theories learned in the classroom. Role-playing experiences in simulation also boosts the confidence of the learners, which is linked to competence and gives patients in real clinical settings peace of mind. I think the video here does a good job of wrapping up and showing the importance of simulation training and the many ways it can be adapted. It also does a good job of explaining how simulation training can increase competence in the real clinical setting after having used simulation-based training. It runs just a little over 4 minutes. I've included the link on the page and will also post it in the comments section just in case there are any problems with playback. I hope this presentation has given you a better understanding of the importance of simulation learning.
Some might think it's just never going to happen to them, or I'll learn enough so that when it does happen, the simulation won't even matter, but you will be put in a situation that you may not be that ready for.
Brand new doctors, they go right into residency. When they get into the hospital setting and they're actually having interaction with patients, that's when they start performing these procedures. They graduate and they get done, and then they throw everybody into this setting and they're expected to function like a unit. Doctors don't go to school with nurses, and nurses don't have classes with doctors, and they've maybe never even assessed a dozen patients yet.
Usually we would have to review a textbook, or they would talk to us in a classroom type setting, and then we would kind of role play an actual pretend scenario. We do see septic children occasionally.
It was very chaotic. Everybody shouting out orders. You had a mid-level, you had the physician, everybody, trying ideas on how to save that baby. The baby ended up having a heart defect, and there was nothing we could have done to save the baby. And that's where we kind of realized that we need some work here.
We do in situ simulations, which basically it's a Latin word that means in its original location. So where they actually perform these tasks is where we need to go. Getting all logistics in there, getting the bed, the mannequin, anything from crash carts to CPAP machines to a ventilator. We take all these logistics and figure out the best need for the learners. We can make the mannequins lose pulses, lose breath sounds on one side or bilaterally. It's like a real person.
It was so helpful to have the simulation done in the room that we would be potentially resuscitating a critical child. We actually redesigned our entire Trauma 2 room to make it more kid-friendly.
Going through the jump simulation, we just decided that we have to change the system. We redesigned the crash cart. Everything is visible, everything is labeled, and everything is right there. It's made a big difference, and I've been in a pediatric code since then, and it went much smoother.
Within my first 2 weeks, of starting my third year at OSF, I encountered a code blue situation on my internal medicine rotation, and a gentleman's heart stopped, unfortunately, and I did what I was supposed to do. I went into the room and looked around to see if I could help with, and I felt very, very comfortable in that situation despite the high amount of stress that was involved. The real positive thing that I took away from it was realizing that I would not have even been able to feel that comfortable trying to help save that person's life had I not done that simulation workshop just a few weeks prior.
There are some learners that realize, oh, okay, they're after the big picture. It's exactly right. We're not looking at the picture with a magnifying glass. We're stepping back and taking a look at the whole frame. Seeing where their heads are at, where they're thinking, why they did what they did. That's the value, that's the key. Is we're not there to tell them they're wrong. We're there to alter the perception of what they need to do. And when you alter that, you improve the quality of patient care.